I just want to give you an idea of the agenda this afternoon. Our speaker this afternoon is Dr. Felice Orlich, and I'll introduce her in a couple minutes. But after she talks, she's going to help moderate a panel of family members who have a member of their family on the spectrum, and we'll get their perspectives on that. I think there'll be a little time for question and answers too. When I was thinking about people who could talk about families, it became apparent very quickly talking to some of my graduate students and thinking about clinicians in the area that we really couldn't imagine a better person to talk to us today than Dr. Orlich about children and adolescents and the spectrum. Dr. Felice Orlich has a mind and a heart tuned to the world of autism. It's very apparent. She earned her Ph.D. at UC San Diego and completed her clinical internship through the Child Development and Rehabilitation Center at Oregon Health Sciences University with an emphasis on pediatric psychology. Her research and clinical work focuses on the assessment and treatment of youth with autism spectrum disorders, with a particular focus on defining treatment pathways tailored to the individual needs of these youth, and implementing these in state-of-art care for individuals and their families. She's been doing this for over 20 years now, so a lot of experience with this. As a clinical associate professor of psychiatry and behavioral sciences at the University of Washington Medical School, she serves as the attending at Children's Hospital and the director of community outreach. She's also very active in educating the next generation of clinicians who are going to be out there working with our siblings and family members and individuals on the spectrum. We've had the pleasure this year of placing one of our graduate students with Felice, and I've heard wonderful stories about the training and experiences that she's getting, and we look to continuing that relationship over time. So thank you for being with us today. Would you join me in welcoming Dr. Felice Orlich? Thank you.
I'm going to try not to trip over the cords. Gary did a good job not tripping over them. How many of you were here for the earlier presentation? So I'm going to go through the beginning of my presentation relatively fast, but it's a little bit different than the way Gary talks about autism. So I'm both a clinician and a scientist working in this area, and I am also a parent of a child with autism, or an autistic child, which I've learned I should really be saying from the young people who were up here earlier at the panel. And I actually think my son would agree with what you had to say. My family is here as well. My daughter is going to be on the panel later on, so you'll get a chance to hear the perspective of what it's like to travel on the autism spectrum. And for me as a provider, it's an interesting world to straddle, doing both. Today I'm going to talk about autism and how to support and foster success in elementary age kids and teenagers. This is a big topic. I have a lot of slides. You have those on those little drives that you have as well, because I'm going to bounce back and forth between some of the research that we've done, primarily in the schools, and also interventions more broadly for kids on the spectrum. So I apologize. I know there are a lot of families and people of different ages and ranges on the spectrum today. And just to kind of go ahead, talk about this, I think Ben put this really well, is that if you know one person with autism, you don't know another person with autism. So you need to know your penguins. I thought this was a really good slide, because what it shows is we all know what a penguin is, but there are so many variations. And that's what autism is about. Autism is a heterogeneous disorder. That means it comes together in a myriad of different ways, with kids having kind of some really variable kind of cognitive skills, ranging from well below average to well above average, right? And in our family, we're fortunate that our child is on the well above average of end of that spectrum. Although I would say when he was younger, we wondered. We know that kids have very different strengths and challenges. And I think that one thing that came across really well that is a strong core belief of mine and the folks at the Autism Center as well, is that the strengths that people with autism have are strengths that we really need to value, right? I think the goal is not to make autism go away, right? A cure for who someone fundamentally is. The goal is really to take the strengths that people with autism have and bring them to bear in a really positive way in society. That's a goal. That's the goal of every parent for their child. I think rather than focus on disability, it's more like ability and how to really make that work. It's really sort of, my view is strong. And perhaps having a child with autism, some people, I would never, my son's name is Jonah. And there are some things you want to change in any child. I mean, he's as stubborn as can be. He's 13 years old, right? He's a stubborn kiddo. But fundamentally, who Jonah is not a person I would want to change. Like his way of diving deep and looking at the world is really unique, right? And it's taught me a lot, and I've learned to look at the world differently as a result as well. So I really want to say that while I'm standing up here. We know that autism also occurs in a broader context. It occurs within the context of a family, right? Family supports and sibling supports are almost as important as the interventions that we give to kids with autism spectrum disorders. It's important to know. There are many stressors that occur as a result of having a child with autism, both just in terms of the functioning of a family, the additional expense and time needed for intervention, and as well, what we sometimes think of that's shadow syndromes that happen in family members where we have a kid with autism as well. The other piece of the puzzle is that we know that in kids with autism, we see a higher degree of medical challenges, ranging from seizures to other kinds of medical issues as people with, as Gary talked about, as we see the population that we're studying and following growing, we're seeing a higher proportion of medical concerns in that group. And sleep disorders are a significant challenge for this population. And I want you to all think about that because that's a core thing, which is really on our radar as clinicians right off the bat. If you don't sleep, your day doesn't go very well as any person. So this is something we really try to address. And the other piece of the puzzle are psychiatric and mental health issues. And this is very variable across the spectrum of autism. But I would say for a good proportion of the kids that we see at the Autism Center, and one of my team members is sitting right here in the front of the audience who I see kids together with on Fridays. But what we would say is that for many of our kids, we're looking at co-occurring mental health issues. And that can range from learning challenges through up the way to anxiety and depression, and as well, mood regulation disorders and sometimes psychosis. I think Ben put it really well. I don't think Ben's here anymore, but I think Ben said it really well. He was one of the panelists beforehand of adults, autistic adults. And what he said is if we don't address these issues, the rest of life will be really challenging. If you think about the world of a person with autism, and I think my son always explains it really well, where he'll say, I can't shut the sounds out. Most of us can walk a pathway and be selective about what we're looking at and what we're looking towards. But for an autistic person, doing that is nearly impossible. That's not a choice. If you have anxiety or depression, all of the stimuli is amplified for you, and it makes life even more difficult to negotiate. So I think that as much as we're addressing autism and the symptoms there, we also have to pay good attention to co-occurring issues. And I hear this from the teens I work with all the time. Okay, we talked about this a little bit, Gary did. The prevalence of ASD is 1 in 68. that varies among different communities. Is there anyone here from Bellevue? So Bellevue's incidence is 1 in 38, right? A much higher incidence in the Bellevue area. And that beltway from Lake Washington to North Shore School District, the prevalence is 1 in 41 as we go out that way, and then 1 in 45. So we also see variability in the state for the prevalence of autism. Why has a lot to do with the industry that surrounds those areas, who provides insurance for ABA that you can actually access. It's an important thing to note. And school district choice, which parents make. And then there's the question of what does Microsoft and Boeing bring to the table. But we don't need to go there. But it does give you an idea of the success of people with autism. So in any case, sorry, sometimes I joke around a lot, so it's okay to laugh. So one of the parents here, we talked about having a sense of humor, and I would say that in our family, a sense of humor is pretty key to surviving, having a kiddo with autism. Right now, and this is important to know, our prevalence is that for every 5 boys given a diagnosis of autism, there's 1 girl given a diagnosis. With our changing understanding of how young women and young girls are affected with ASD, those prevalence estimates could change. Because I would say right now they're an under-identified population of individuals. And potentially diagnosed later if they're on the higher functioning or have higher cognitive skills. So I wonder if this estimate right here will change over time, and that's my expectation. We talked a little bit about resources, and I just want to interject at this point surrounding resources for girls with ASD. We have groups for teen girls with ASD specifically that are focused on social anxiety and social skills. And that's a really unique service that we offer through our anxiety clinic. And it offers both intervention, but it's also been a really successful modality for us in treatment. So I just want to let people know that's a resource out there as well. Okay, why is autism increased? Well, we've gotten better at diagnosing it. That's one piece of the puzzle. We're also diagnosing more kids who are higher functioning kids, for sure. We think maybe there's been misidentification in the past. And there is a suggestion in the research that there is some true increase as well. Why is a good question. We do think that there's a genetic component. Autism is a genetic disorder, and there could be genetic drift in the population. There could also be an environmental impact to autism, but it would be a small proportion of the increase that we're seeing. So we think most of the increase is due to our getting better at diagnosing. And then there's something else at play, but we haven't quite identified what that is just yet. Although there is a lot of research out there. I could spend all of today talking about that, but you'd be really bored because it would be a lot of numbers. And the important thing to know is that we're looking for the genes. We're hoping that at some point what we know about people's genetic predispositions and makeup will help gear treatment, but we're light years away from that, I would say. Right now, the best thing to do for your child and for yourselves, if you're a person with autism or an autistic adult or teenager, is know yourself. That's going to be the most important piece. And for the clinicians here, know them and listen to them about what they need. Okay, it's really key. I read this really cool essay that a person who's an ABA therapist wrote recently. And she talked about her experience when she was a young person who came right into the field and had this technology for working with kids with autism. I almost use the word training, right? Because that was really how she came across. And what she said was, I came in with all these tools and ideas for how I was supposed to teach this person with autism what they were supposed to do. And what I learned much later when I had my own children is that I should think about if I would make my kids do those techniques, right? and if I was really seeing it from that child's perspective of how I was coming across. So when you think about this as a clinician, as a parent, and when you're looking at what's out there, think about if you would want this for you, but also it's okay to be a good consumer and to say, this may not be the right approach for me. This may not be the right approach for my child. But make sure you're evidence-based about it. So chelation, those kind of things, not right. But ultimately, you're the expert. Who you are as a human being is an expert, and as a parent, you know best. Use your intuition. Sorry, that was my rant. I apologize for that one. We do know that there are some things that don't cause autism. Vaccines don't cause autism, okay? If you don't have a vaccine, though, if you don't vaccinate your kids, it could lead to other problems in our society and also for your kids. And we also know that autism is not the cause of bad parenting, right? That's pretty clear. Okay, whoops. Autism generally, we're pretty comfortable diagnosing by the time kids are 2 years of age. And there are ways, and clinicians who are really skilled in diagnosing kids younger than that, from about 16 months of age. And we will try to make the diagnostic kind of picture for us go younger than that. But right now, the younger than 2 years of age is really left to the hands of some people with really good expertise. And then there are other people, David and I got to do that this week, right? Who we don't diagnose until they're teenagers and older. And there was a woman in the audience who wasn't diagnosed probably until she was in her 50s, right? So when people are diagnosed, hopefully it is becoming younger, but we do see older folks as well. Okay. Autism there's no medical test. It's really done both by evaluation and a careful history. Our primary tools will include a good developmental history as well as something called the ADOS. How many of you have had your kids evaluated and been evaluated for autism? Okay, so you kind of know what it looks like. So I mentioned this already. There is no cure for autism. The question is really going to be based on who your child is, what therapies might fit for them. And some of those therapies will include, it says private therapies, but I think the private should come off of there because a lot of these are available at school. Will include speech therapy for some kids, not all, although it's pretty common for us to recommend that there's some level of speech and language therapy, either for kids who are nonverbal, right, to develop language per se, up to kids who really need to work on conversational skills, or what we call pragmatic skills. Occupational therapy services are often recommended both for adaptive skills like fine and gross motor, as well as sensory challenges. And I think the panel really talked about those sensory challenges that we see. As well, some kids will need physical therapy. Physical therapy was the first thing that our son accessed as a little guy. That was our entry into the diagnosis, I would say. And then to address the mental health issues, there'll be individual therapy, social skills groups, medication management. You could see that there's a whole palette of therapies. Part of our goal through our process is to really help people prioritize, because if you get on the internet, you could feel like you have to do all of this at once. And you probably will want to when your child is first diagnosed. But the reality is prioritizing is important. The core method for intervention for younger kids with ASD, and also for older kids, in our state, the ABA benefit is available through Medicaid through age 20. Probably should go beyond that, right? There are some companies, including Microsoft, whose benefit extends beyond that age range. But ABA is the primary mode of therapy. And ABA is a technology, right? It's not a kind of treatment. It's a technology for approaching both skills acquisition, like acquiring skills, as well as helping with behavioral challenges. And it's really individually targeted towards the skills that kids need to develop, both in social communication and also academic skills at times. Do you guys have any questions about that? It's kind of a broad, I'm going to start moving kind of quick. Sorry, guys. And I better watch the time, right? Wow. Oh my God. Okay, 2:30. No, I have to finish at 2:15. So I sort of know my thing. A lot of my research is on social skills. And originally, I wasn't going to talk very much about this, but listening to the panel and listening to Gary's talk earlier today, what I really was struck by was this idea of, in order to support kids with autism spectrum disorder, our supports early on so they can move into the workplace, go to college, gain vocational skills, stay within the community, is to really foster what I call engagement. So rather than, and this was also my learning, both as a social skills researcher, for example, and also as a parent, frankly, to think about, are the things that I've brought to bear as that clinician, that young therapist saying, here's the skill, learn it, be neurotypical, right? Was that always the right way to go? Is that the goal, right? And if that's not the only goal, what is it about what we give to kids when they're younger that helps them stay connected to the community when they're older or seek it out? So social skills groups are our primary, that is the #1 recommendation on all of our reports, right? Social skills groups. But there's not great evidence to date about what kind of groups work and for whom. It's pretty much social skills groups. How many of you have been in a social skills group or had your kids in one or been part of a lunch bunch or a speech and language therapy group? Okay. And some of you now are in social kind of network groups, more for like older folks. So usually groups are designed with a curriculum involved that focuses on developing social communication skills. And that can vary from greeting somebody who comes into the room to having a conversation, like it's a ping pong game, going back and forth, to learning to read nonverbal cues, to learning to regulate your emotions, right? So there's really a range of skills taught in social skills groups, both from play for younger kids, initially learning to play in parallel or side by side, and then learning to engage cooperatively. For younger kids, it can include learning to make eye contact, right? So there's really a variation in what social skills offer. And our thinking about it is that the groups offer a place for modeling and they offer a place for practice. What hasn't always happened from our groups has been generalization, right? So we've used a lot of interventions in different contexts, and most social skills groups honestly occur in clinic, right? They happen at the UW Autism Center, they happen at Seattle Children's Autism Center, they happen here at SPU in your research programs. But what's challenging is that it's been difficult to generalize the skills kids learn in group to the natural environment. And that natural environment for most kids, younger kids, is school, right? And even in the school-based groups, we haven't seen good generalization to the classroom. So when we were thinking about our research about social skills, our question was, well, what could work? What could help kids' skills? That's originally where we were coming from. And what we looked at is some of the research in little kids, which showed that bringing in neurotypical peers could really be effective in helping kids bridge the gap. We didn't always see that with older people and kids, but we knew that for younger kids, that might be the way to go. So what happened from what we learned, that generalization from clinic to the real world wasn't very good, and that perhaps just putting a group of kids with autism and other learning challenges in a group together wasn't going to help them get engaged. We worked as a multi-center, this was a huge study, where we first decided we needed to do our interventions in schools. So our goal was to move away from a clinic model and move to the school. Now, this is not research for the faint of heart, I will tell you that. We were very lucky because we got a very big NIH grant, which was my study, and it was across Seattle, UCLA, Ann Arbor, and Baltimore. So a big study. We had about 500 kids in the study. And what we did is we had two arms. One was for elementary age kids with autism, and broadly, I should say broadly, these were more also kids with other social skills challenges, and then a teen study. And we had the kids went into one of two arms. One was where we only had kids with autism. That was one group of kids. And in the other group, for the elementary age kids, were kids who were typically developing from their classrooms. How we picked those peers, we called them our peer models, let's say, was by what we called a social network. And there's a lot I could explain in that. We picked the kids who were kind of, other kids said they wanted to be friends with for our group. And that may not have been the best choice for our elementary age group. But the idea was that the kids would go into groups, these two different groups, twice a week. And what we wanted to look at is whether or not the kids were more engaged after being in this group, and if they showed better pro-social skills, or sort of initiation, playing with other kids. And our expectation, so I should tell you, just for me, because I'm the researcher in this, is that there's some tension between the UCLA model and ours, because we're kind of sometimes like the Prius of intervention, in that we kind of wanted a hybrid model, where we said we need to be structured in our approach, but we want peers. And UCLA said, no, when the peers are there, we just want it to be loosey-goosey for the elementary school kids. So we did that because it was their intervention. But it was good because it taught us a lot. But it was very fun because the Seattle model won. So we were psyched that we won. So I was happy about it, at least, to be the winner. So part of our study looked at our outcomes was to ask like an entire group, like an entire first grade. And we would say, who do you want to hang out with? Who's your friend? Who's your best friend? And we asked them before the kids went into the group, both the kids with ASD and the rest of their class, who you're friends with. And then we asked them after the groups were done as well. And what we made is this thing called a social network. You could do this with your Facebook friends if you really want to. So, you know, like we joke about this with Facebook, but for us, this is like a serious research methodology, believe it or not. So K11, this kiddo over here, and this kiddo is a third grader, is nowhere in this social network. Nowhere. They're on the outside of the network. That means they're unconnected. That means that K11 was not identified by any of the kids in their class as someone they hang out with. And K11, let's call her K, also didn't say that she had any friends in the classroom either, right? This is a striking kind of example of the isolation that kids with autism can experience in elementary school. So after our intervention at time 2, this was so cool to see, right? K moved up to have 6 ties. That means she identified 6 friends, and 6 kids identified her as a friend. So our intervention worked, right? And what we thought was that we would see more Ks coming out of our peer-mediated group, but that wasn't how it worked. But there was a unique element in our group that doesn't usually happen in social skills groups. So the way that our groups looked is that the kids would get together at lunch, and they would have a group, and they would play some games together, or they would learn a skill. And then we planned with them what they were going to do at recess. That was the difference. That's the core difference from what happens with most social skills group, where that plan doesn't happen. And then one of our graduate students would go out to the playground with the kids, right? So we were also teaching the kids, irrespective of group, we were teaching them playground games. So we knew the culture of the playground and we learned those games. We learned Foursquare, wall ball. We learned all kinds of cool games. We learned games I didn't know existed. So that was pretty fun. Played dodgeball again. That was dangerous. And we did this at my daughter's school. She might not remember that, but we did. And what was nice about that is that what we saw over time was because we were facilitating the play on the playground, we had other kids come into the play. So I think what was core here was that we were structured about what happened from the group to the playground. And that was probably one of the critical ingredients to why K went from the outside to the inside. Does that make sense? So the outcome from the study was that, and this I didn't really cover as much, but inclusion of neurotypical peers was important, but the way that we structured it was equally important. It was interesting, though, because we didn't see that the kids in the autism-only group we actually found that those kids were more engaged than the kids with just neurotypical peers. It probably was the structure, but then we started to think of this other idea, which I think that the autistic adults talked about today, which is the idea of homophily. It's a weird word, right? But think about, as an adult, who your friends are, right? Your friends are people who share your interests. Your friends are also your neighbors. That would be propinquity, right? And when we create groups for kids and adults on the spectrum, we're often thinking about their diagnosis, which is what I would call propinquity. We don't always think about homophily, which is shared interests. And what we see qualitatively in the community, like for example with the groups Aspiring Youth does, someone's here from Aspiring Youth, right? I know you are. I saw you out there. So at their table, they were showing the game Dungeons and Dragons, right? That's a great example of homophily, right? There's a shared interest that people have and come together with. So one of our thoughts is, how do you balance that? Right? If we have all kids with ASD in a group, right, we may have better homophily. The kids might find their shared interests. Is that me? Oh no. I do these things sometimes, I apologize. So it was interesting. My son Jonah was just a state finalist. We're very proud of him for the National Geographic Bee. And after the final championships, where he choked, so he didn't get as far as he would have liked, I have learned more about geography in the last few months than I ever thought I would know, but it is slowly escaping my mind. So, but other folks have said to me they were really into geography too. It's amazing what he knows in that brain of his. But in any case, after the state final, he said to me, it was really cool to be around other kids like myself. You know, it was really cool that there were other kids who were just as involved in geography as he was. So then I had this wish that there was just like a geography club that he could go to regularly to meet other kids who could talk about exactly the level of detail that can you remember it? I can't even remember things anymore. So really it's like out of my mind. But what it was about was homophily. Like, I'm sure that I could more frequently get Jonah to leave the house to do something homophilous than telling him to do something he's not really interested. Like, just taking him to a group because it's a social skills group in my neighborhood isn't sufficient. That was really the bottom line of the study, is that's not sufficient. So that means we should change the way that we do groups, right? We found that structure is important. We found that homophily is important. It was probably more important to pull kids with shared interests than it was to pool kids who were in the same class. That was really one of our bottom lines. In our teen study, and now I'm going to go through this really quickly, in our teen study, we actually did that. And so what we did in our teen study, Engage is where we brought typical peers in, but we were really choosy about our neurotypical peers. They had to share interests with our kids on the spectrum. And what was cool about that is that we got to see, so this is frequency of talking and texting, we saw that right after the group ended, that kids in the Engage group, where there were more shared interests, did more talking and texting with each other and new people that they met from kids who were solely had ASD, where they weren't necessarily homophilous. We also saw that their stress, like their social stress post, was much lower than kids in the skills group. And this was an interesting finding for us that we saw that difference. And we also saw that, and this is upside down, but we also saw that kids in the Engage group were more socially engaged than kids in the autism-only group. But the difference with our little kid group was really around how we chose people. So we were pickier about our match. So I'm gonna kind of go ahead. I have not too much time left. So there's a lot of stuff in your handout with the specific strategies, but what I wanted to just bring to bear, because this really came out in the panel as well, is that there was a survey done by the National Autism Association in the UK in honor of Autism Awareness Month, this month, or Autism Acceptance Month. And families and people with autism came back with these are the top 5 things they want people to keep in mind when they're understanding behavior, or because behavior serves a purpose, right? Behavior is a communicative strategy. It's not just a behavior. Behavior is a way of speaking. That's how I think about it. And what they wanted to say is, this is what my behavior tells you. My behavior tells you when I'm not really looking comfortable, when I'm withdrawing or acting out, that I need extra processing time. Ben said that really well. He said, I need more time to do things. It's something that I need to accept in myself, but it's something other people need to understand about me. That social situations are anxiety-provoking. That change is not my friend, right? Change is... How many of your kids have a really tough time with transition? We're all raising our hands. My family really should jump up and raise their hands for this one, right? And that sensory overload, which these guys talked about, at length, and that overload and all of those things can lead to meltdowns. So I'm going to be really flexible. Put that down. Alrighty. So some of the things the way that we think about it is that when we're thinking about those top 5, our job on the outside, and eventually your jobs on the inside, is to think about how to manage those top 5, right? And from our perspective, I'm a psychologist, so I use behavioral principles. And the idea is to really think about the environment from a child with autism's perspective, or an individual with autism's perspective, and think about how I can reduce some of the sensory input and the environmental input for them. I think one of the examples that the older woman with autism gave, that she goes to Costco earlier in the day, right? How many people here sort of change their schedules to meet this need, right? Give more time than you might in the morning, right? Go to the movies, go to a matinee. That's a good example, rather than an evening show. And these are all kind of examples of things that you might do. I also think that, just thinking about that top 5 is that people with autism have unique strengths as well as challenges. And I think that when we're thinking about it, not for everyone, I wouldn't say visual spatial skills are always great for all people with autism, because remember my penguin You have to know which penguin you're working with in this. Not that people with autism are penguins. I want to be really clear about that. Maybe other animals. I really love animals, so it's not offensive to me to have that animal analogy. Some of the challenges that we see really surround communication, getting your point across, right? And I think you guys all talked about that on the panel, that communication can be difficult, knowing how to say what you need and how to get that across to people. Short-term memory can be difficult, but on the other side of it, long-term memory, details, remembering everything you once said, really. Arguing, how many of you have tried to have the argument? You said, I said, with a person with autism, you are losing for sure, right? You're going to lose that one. Rigidity can be difficult, not being flexible. Losing my necklace in the middle of a talk would be really challenging for some people with autism, but following the routines, structures, being a great employee, right? A lot of technology, a lot of industry is seeking out people with autism for this very reason, right? This is a unique ability. I would tell you, as a person who works with teenagers, right? A teenager with autism will follow through with treatment strategies much more readily than a neurotypical teen, okay? Hands down, I'll take a kiddo with autism, a teen with autism, over a typical teen any day. That's just, with the exception of my daughter, of course, who's sitting here. I mean in therapy. I'm going to hear about this later. Okay. Social isolation, or the choice to be on your own, that's another way to think about it, can be seen as a detriment in people with autism, but the potential for working independently. Now, in our current society, there is the option to do a lot of work from home. Being a computer programmer, working at code, doing a lot of mechanical work is more of an independent work, kind of. Perseverative behaviors really means stick-to-itiveness. It means that you can stick to it in a way that none of us, most of us in this room, with the exception of people who are autistic, can do. Special interests can really be leveraged, right? I think that my son's interest in geography could be leveraged into a great political career. So in our house, right, politics are a big thing. My son is a Bernie Sanders supporter. Go Bernie, yeah. I caucused with him. It was an experience. But part of it is geared around that interest in geography. So entree into something that's politically and sociologically relevant really comes from that interest. It's all about how you work with it, really. So the other piece of the puzzle, which I'm going to talk about for one more minute, are positive behavioral supports, which I think are key. And again, you guys, the way that I do my PowerPoints at this part of the talk is the strategies are built into the little drive that you have. So I always talk more than I'm supposed to, or use more PowerPoints than I'm supposed to. So I'm going to go through these things that you can think about. One is, it's very important to use strategies to decrease anxiety. And the way that we think about this is to remember that providing the opportunity to approach things that you're uncomfortable with is really important. And I'm saying this for the parents and for the adults in the audience. It's really easy because your kids are really uncomfortable in situations to completely avoid them. That is the strategy of least resistance. But the important thing is to titrate exposing them to situations that are uncomfortable, because they will need to enter them as adults in the world. Okay? So the way to do that is by breaking things down into small pieces and expose them to things that are challenging and using a lot of rewards to keep them there in that situation. And you do it slowly. It's not just what we call implosion. Throwing them into the pit of snakes is not going to work, right? It's just not going to. They will definitely escape, right? And avoid and fight. I mean, that fight or flight's a strong response. But it is very important to think about anxiety-provoking situations and how can you get them there, but in small pieces. Okay, avoidance is not a good strategy. Because when you think about what Gary was talking about the workplace, the more that we close the doors on our kids' life on a day-to-day basis, the more that they won't be able to access the environment later on. So it is where the balancing act comes up. Okay, what's important as a strategy. You can also think about reducing the stressors you do know about, as well as teaching the kids coping strategies. And that's a talk on its own, which I'm happy to come back and give another time. But, okay. And we know parents are crucial, siblings are crucial. We need you. You're the generalizers of skills. As siblings get older, likely for many of you, you are going to be the bridge for your siblings down the road, and you play a really pivotal role. I know that's a stress. One of the kids here, I think I see the mom in the back now, but I don't know. I see the girl. Natalia, it's your siblings. I think that for siblings, as they get older, one thing that she shared with me, your sister shared with me, is that we really need to pay attention to siblings and the roles that they have in their emotional adjustment as they get older because of their place, and even in who they choose as their partners in life can really be sort of influenced by who their sibling is. So it was an interesting and a good reminder to me. Okay. The other things to think about is how you communicate expectations. One of the things that we know about people with autism is that they can really look like they understand what you're saying, right? Great at memorizing things, but it's important that you're clear. And those things are on there too. Structure is important, the use of visuals. And I put that in there because we'd like to surprise the kids, but that's part of the anxiety piece, that we don't want everything to be hyper predictable. It's really funny when families come in and say, our family's not as structured as I know you're going to tell me to be. But their kids are pretty flexible, as a result. So again, there's this balance between structure and helping your kids to learn to be flexible. In the interest of time, because I know you have to get the panel on the stage, Bev, I'm going to jump ahead. And I'm going to tell you where I want to land with all of this. And there's lots of sensory pieces in here too. And this is the most important thing for me, and I know this is a really touchy-feely slide, but when you're thinking about people with differences in general, the idea is not to feel pity, right? It's to be inclusive, right? And to accept them for who they are. I know this is a touchy-feely slide, but it's really what I want to leave you with. So can I take a couple questions, Bev? All right, so questions? Yeah.
How do you pick your peer groups? Is it more by age or kids who would be able to teach the social skills better?
That is a really good question. So the question is, how do we pick peers for groups? Like, what was our learning? So our learning, because we had differences between UCLA and our site, and the way that we picked our kids was via the school counselors. And we picked kids who were already in helping roles at school. So they were in some schools it's called AVID. There are a number of different groups. We picked kids who are in things like band and drama because they're already a little bit quirkier than other kids. We picked kids, we had this whole interview form. We picked kids who had siblings with disabilities. That was another choice for us. And then we picked kids who shared interests. That was how we did it. We also taught them how to be peers, peer mentors.
Is there an age range? It's better, if I'm working with kindergartners with autism, is it better to have first, second graders, kindergartners, or sixth graders?
Younger kids, preferably.
Like how much?
I would go K through 2.
Okay.
Okay. Yeah.
You mentioned ADA for all ages.
Yep.
My son was diagnosed later.
Oh, my son was diagnosed later, and there wasn't ABA yet.
Right.
For his older age, he was over 7. And then when the autism parity passed, I went to find an ABA therapist, and they didn't want to take him because they said he was too old.
Yeah.
So
And
how does it work for an older person?
how does it work for older people? That's a really good question. Is ABA appropriate for people older, 7 and older? Because previously we were really focused on saying, well, ABA therapy is most appropriate for younger kids. And I would say most ABA therapists, sorry to the ABA therapists in the audience if I'm misspeaking, really are trained to work with younger children. For older kids, what will more likely make the recommendation for ABA for is in the acquisition of adaptive skills, for example, as well as behavioral challenges. So, and remember, ABA is a technology, right, for intervention. So that's really how we would be approaching it. Unfortunately, there's a lot of work for everyone to learn to do, and people aren't always skilled in working with older individuals with autism. So it's hard to find the right person. If you do have questions about who might be a good fit, it's worthwhile to connect to our family resources folks at the Children's Autism Center, because they can help figure out who might be a better fit. But I know with autism parity, we have also flooded the system, right? What Dr. Stobie was saying, in that we make the recommendation now, but we also know kids will sit on a wait list for about a year, especially if you have Medicaid, right? You're sitting for a long time. So we haven't, what we had hoped, and we all wondered if this hope really, like many of us, me standing here, people sitting in the audience, knew that we would open the floodgates, but we wouldn't have the interventionists, and that is where we are right now. So part of our goal is to train people. Like as a professor, my job is to train more people. But especially, I work with older kids, and there aren't that many people out there who do. So, I saw another person wanted to ask a question. Wow, okay. So we're ready for the panel. Thank you.